Yeah,
Yes,
that's
that's fine.
working.
Great. Okay, so my name's Kassim Javaid, and I'm a academic rhematologist from Oxford. I'm actually chair of the Medical Advisory Board for BBS, a great privilege, as well as principal investigator for Rudy. And these are my personal thoughts on treatments and remote consultations, where we were, where we are, and where we're going forward, really. So the care for adults with OI, we really do focus on the specialist centres, but there are other specialists we depend on, orthopedics, but also hearing. We need a lot of support from local hospitals if people don't live near the specialist centres. Obviously, we have to coordinate with general practice, who are the primary sort of contact point for many people, as well as integrate with supporting therapies, mental health services, wider rehabilitation, wheelchair services, and where needed, employment and benefits. So before COVID, how, we have to remember that before COVID, we weren't doing, we thought we weren't doing that great. And I'll just share with you, there's this really great study that Stephen Morris ran called Concord. And he's actually got a very lovely webinar you can watch. It's quite long, it's 2 hours, but it really does go into what was happening with coordination of care before COVID. And it's a really good summary. And this is their sort of very complicated journey from how to organize care, responsibilities, how often, access to records. And I found it very useful. So if you want to dive a bit deeper, do go to Genetic Alliance website. And the Brittle Bone side with Patricia were instrumental in supporting the Concord study to make sure it stayed real for people. And their summaries, most adults don't have access to specialist services. It's routine, rather sadly, that key patient information is not shared between services. Often one specialist doesn't know what's happening in another team, leading to gaps in care. People have to take lots of time out, multiple clinics, different hospitals, different sites, and that takes a lot of time and travel out of their own lives. Most adults don't have a care coordinator. And sometimes you're seeing a health professional who maybe doesn't have the relevant experience in rare conditions. And that's really frustrating. You've been waiting so long to then meet someone who maybe has never met someone with OI. So that's how we were doing before. And then we had the disaster, the very difficult COVID pandemic. And that has, as Adrian and others have already stated, a huge impact. For secondary care, so hospital care, many services were redeployed appropriately to focus on the massive influx, but it was very different across the country in both the first and second surge. A lot of people became sick, healthcare professionals died or had to take time off. Routine clinics were very low priority and shut down very quickly, and clinics were often restarted unscheduled, and I'll talk about going remote. For therapies, there was no day unit. They were all reconverted to manage COVID. So people having infusions such as alendronate were put off. Imaging was delayed, non-urgent imaging was paused, and pretty much all elective surgeries, Adrian's already mentioned, were stopped. But even primary care, recommendations and letters from secondary care just weren't getting acted upon because GPs were struggling with the COVID pandemic at the GP level. Tests that we often rely on GPs to do, blood and urine tests, weren't getting done, and a huge impact on community therapies as they were redeployed. And it affected people living with long-term conditions. They were scared to come into hospital. They didn't find it easy to access GPs, as I've already mentioned, for blood test treatments or to injections, such as denosumab. Access to pharmacy was troublesome, and access to hospitals was more difficult. We had fewer slots for face-to-face, and so delays were inevitable. Perhaps the really important thing to remember, these responses weren't pre-planned. They were really made up on the fly, and they're very reactive in a very short time frame. And it's probably a fair statement that patients were not involved in that process co-development. Many of these decisions were made by clinicians, and there weren't patients there to help say how to co-develop the services during the very short time frame we had. This is a map of COVID cases per million from most recent, from May last year. and you can see black is obviously bad, and white is good, and the colors of red in between show the varying rates. And you can see it's a very mixed picture across the United Kingdom. And some services stopped, some were paused, and some did manage to keep going. In terms of treatment, there were guidelines published by NHS England. Many specialist groups got together, and the summary really was it's okay to delay intravenous alendronate, but not to delay denosumab, which is sometimes used to treat adults with OI. There was some international guidelines produced or advice for people with rare bone diseases at the European level, led by the ERN, European Reference Network, reminding people to, follow the general recommendations. Don't forget your rare disease care and treatments, the importance of calcium, vitamin D, and highlighting special recommendations for trauma, for people with broken bones, during pregnancy, the importance of mental well-being and mental health, and also the impact of carers who often at the beginning weren't as very variable in the level of PPE and care protection they had, and led to a lot of anxiety with some of the individuals I care for. And they produced this list of people who may be vulnerable, and I think this is really important. Even in this guideline, they said these patients could be susceptible to more severe complications, and we're really around the chest wall abnormalities, and severe OI was top of the list, really. So moving on to consultations, the old way was the regular face-to-face clinic every 3, 6, 12 or 24 months, where we listen to patients' problems, and then we'd do a routine screening history, we'd do an examination, maybe organize same-day x-rays and same-day blood tests. With the pandemic, lots of people were too afraid to attend. We went remote, which I'll talk about what that actually means, but still we had a big focus on patient problems, but less so on our ability to examine. We couldn't pick up those early signs that maybe people hadn't noticed. There was no way we could do same-day radiology. You have to wait for same-day x-rays and same-day laboratory tests, and face-to-face clinics were really only reserved for urgent cases where we weren't sure what was going on. We couldn't handle it with a remote consultation, whether telephone or video, and we had to get people in. As Lisa and Claire have said, there are lots of advantages to a remote process, which could be either by telephone or video. You don't have to travel. That's a great bonus for people who are working, or people have to take off time to come. Maybe they need someone to drive them to the hospital. Parking was a great godsend, not only for the doctors coming into the hospital, but also for the patients. You don't have to pay or park. And many people could keep working and maybe just drop out for half an hour for that consultation rather than having to take the whole day off. The barriers were technology. You need technology to access a remote, especially video. You need a safe space, and this really hasn't been discussed. You need a space that you feel comfortable in and is secure for you and is quiet, and only the people you want to hear can hear what's going on. And that really hasn't been as well thought about, because we had no time, really. We've already talked about the backlog in orthopedics. The backlog in imaging is very variable. In some centers, it's been fine, they've kept going, because a consequence of not being able to see people is that we often have to go on the symptoms and then do a broader set of imaging, because we're not quite sure on the history or on the video what's going on, and we order a different set of imaging tests. There's a backlog in day units. I think most are now catching up with infusions, and the delay in clinic appointments is very variable. Some centers have actually kept going and actually not got a backlog, whereas other centers, because of the amount of COVID, had to redeploy their entire staff and now have hundreds or thousands of clinic appointments to catch up on. So what about going forward? Well, it's going to be a new world, and we will not go back to pre-COVID. That's very clear. And all the signals coming from NHS England is that we have to rebuild in a different way, because it's an opportunity. Things weren't great before, and we should use this as an opportunity to build better. I think one of the big things is that we have to provide resources and support So adults with OI are even more aware of their health. They're more aware of their rare disease health, their non-rare disease health, both physical and mental, reproductive, education, employment. So we can support adults with OI to actually support the NHS services as they transition from pre-COVID to post-COVID. So how can we help people get better benefit from their COVID appointments, post-COVID remote appointments? Well, we need to be able to give doctors clear updates, give doctors hints for when, and clinicians hints when there are early problems, and also help them prioritize their management. And I'm really grateful to have Delaney from FDSS who's worked with me on doing these things. So, you know, simple things like before your appointment, write down any new symptoms that could be related to your rare disease. Your doctor, before when you came to consult, we may have noticed you've got a limp. We won't be able to do that if that's a telephone consultation. Have you got new symptoms? Have you had broken bones since we've seen you before? Falls or nerve or spine issues? Any worsening symptoms? And don't forget about hearing, sight and dental. They're part of our care for you with OI. How are you coping? Think about it on different domains. Physically, how are you coping? Mentally, as well as other aspects of how it's impacting your ability to work, any education or impacts on benefits. And then have your list of medications ready, how long you've been on them for, and have you had any problems. We as clinicians, because we're not as connected as we should be, we'll need to know who else you're seeing, both in terms of departments, but therapists. Who are you seeing and what are you seeing them for? And are there tests or scans you're waiting for? And before you finish your remote consultation, don't forget to ask, what's next? What's my next follow-up? How do I get in touch if I have a question? And what if I have a need for urgent access? So what are the practical things? Really simple. It hasn't happened yet. I've been doing remote consultations for over a year now. Make sure your mobile is charged. Well, if you know your mobile hasn't good reception, say you want a landline phone call. Try and find a quiet place that's private. Pets are pets, and that's just what it is. But if you can have someone to help, that'd be good. It's often been hard on the medical staff, and we often have lots of things going on, and so do be flexible with the time. We may call you earlier or after, and if it's not a good time to talk, just say, oh, can you call us back in 20 minutes or half an hour, or can you call me later? That's perfectly acceptable. We recognize people are busy, everyone has different priorities, and you know, if we have to change our time when we call you, have that comment, say, look, is it possible you can call me back in 15 minutes or maybe in an hour? If that's reasonable, they'll try and accommodate it. For the video, make sure your camera links, make sure you've got the link ready. Sometimes it's useful to have someone nearby in case you have to hold the camera. We may want to see how you walk, how your joints move. We may want to see your joints, so do wear loose clothing. The biggest problem with the camera is actually Wi-Fi quality, and that's something that we'll talk about going forward. So about going forward, these are sort of my thoughts. We've got this box of adult OI care. So how can we have consultations? Well, there's three ways that we can have consultations. We can have them live. So this is face-to-face, telephone or video. And I think, you know, maybe going forward, we have safe spaces. It may be you can go somewhere, either formal or informal, where actually there's good Wi-Fi connection. It's a safe space for use near where you live, rather than you having to come all the way to the hospital. It doesn't have to be at the same time. Sometimes we've used letters usually to communicate if there are problems. They're very slow. You can use voicemail or leave messages, but actually, you know, COVID has really taught us to embrace text messaging and emailing to actually engage with you. So if you've got a problem comes up, you don't need to speak to anyone now and then, but you've got a question that's troubling you. This is where this asynchronous or different time communication comes in. The biggest change is in how care is addressed, and this really addresses the problem that the Concord study raised, that, you know, sometimes you're seeing doctors who maybe not the right doctor or the right therapist or the right clinician, because they don't have the relevant experience. And the solution we're going forward is a network of care, and that whether it's a routine request, an urgent request or emergency request, is a network response which will connect you to the safest and most effective care pathway, whether that's a person or a department or a hospital. What we have to do is make sure this is co-produced and co-delivered. Our systems are here to work with you. So you have to be involved in their production and, if possible, in their delivery. And there's a role for patients, families, carers, as well as patient groups such as the BBS. I'm very keen that we're not going to get it right first time. That's inevitable. We live in the NHS, we're humans. So we have to measure what we do, think about the results, and then work out how to improve them in a cyclical way. I think if we've still got the same model after a year or 18 months, something's not right. We should be changing because the NHS is changing and people are changing, how they're recovering and rebuilding after COVID. And central to this is having a name coordinator. It's really important now. Everyone with OI really should have a name coordinator they can go to, even if they've got very mild OI, which I don't think really happens. People even with mild OI can affect their lives dramatically. It may not be physical, but could be mental. And so we need a name coordinator to take ownership of the entire pathway and actually deliver this at the patient level, having all these great ideas, actually make sure they make a difference to people on the ground. So that's all I was going to talk about, really. Remote consultations are here to stay. There's very many different types. There's different software you can have. Be prepared for your consultation. It's a very brief time you'll have with your team. Be as prepared as you can, and join us. We will be developing these new systems, these new networks, and we are pushing very hard with the Brittle Bone Society to make sure that as part of that regional network, there is very strong patient engagement. We have to co-produce and, if we can, co-deliver these services going forward.